Psoriasis is a chronic skin condition which affects anywhere between 2 and 4% of the population. Because of its chronicity and its tendency to remit and relapse, it forms quite a bit of work for those who manage skin disease. So in this talk, we'll cover the definition of psoriasis, the clinical features of various types of psoriasis, something on the epidemiology of psoriasis, and a small amount on the pathogenesis and etiology of the condition. And then we'll dwell on treatments of psoriasis, which include topical treatments, physical treatments, and systemic agents, which in the last 12 to 15 years have revolutionized the management of difficult psoriasis. So what is psoriasis? Well, it's defined as a common inflammatory skin condition which affects 2 to 4% of the population. It's characterized by well-delineated, well-circumscribed red scaly patches. It tends to fluctuate in extent and severity. There'll be periods of exacerbations, periods of improvement, and even temporary periods of complete clearance. And it's felt to be an immune-mediated genetic disease. Psoriasis can occur at any age, but there are two peak age incidences. That is early onset disease, which tends to occur between the ages of 15 and 25, and late onset disease, which occurs between the age of 50 and 60. It affects anywhere between 2 and 4% of the population, males being affected as frequently as females. It's slightly more common in Caucasian populations, but it will affect all ethnicities. In about 1 in 3 patients, the patients themselves are aware of a close family history of another individual with psoriasis. However, if you take the opportunity of going to examine close family members of newly diagnosed psoriatics, you'll find it more commonly than that. Psoriasis can be classified in a number of ways, but the clinical features are probably the most sensible classification system. The most common type of psoriasis is called chronic plaque psoriasis. This tends to affect the elbows and knees, the shins, the forearms, and may spread also to the scalp. It may be associated with, or there may be entirely only flexural psoriasis. So this is psoriasis that tends to affect the axillae, the groins, the submammary area, the natal cleft and perianal area, and genitals. The scalp is quite frequently affected in psoriasis and is sometimes the only place where psoriasis is evident. Psoriasis can affect the nail unit, and again, it may be entirely confined to the nail, or it may be that there's extensive psoriasis also with nail involvement. Plaque psoriasis can affect the palms and the soles, and we call that palmoplantar plaque psoriasis. There's a particular variant of psoriasis called guttate psoriasis, tends to occur in younger individuals after a streptococcal sore throat. The word guttate comes from drop or drop-like, because this tends to manifest as small 3 to 5 millimeter tiny little patches of psoriasis, although somebody has flicked paint onto the skin and covered them with little dots of psoriasis. Finally, psoriasis can extend and affect more than 80% of the body surface. This is a relative dermatological emergency because people can get electrolyte fluid balance disturbances and problems with heat regulation. So this is erythrodermic psoriasis, when more than 80% of the surface area of the skin is affected by psoriasis. Pustular psoriasis is a less common variant of psoriasis. It may coexist with ordinary plaque psoriasis or appear on its own. Perhaps the most common variant of pustular psoriasis is palmoplantar pustular psoriasis or palmoplantar pustulosis. But this is genetically and therapeutically quite distinct from chronic plaque psoriasis. And a lot of the medications we've got to treat chronic plaque psoriasis just don't work in palmoplantar pustulosis. Plaque psoriasis elsewhere on the body, for example, the shins, arms, trunk, can develop localized pustular lesions within them, often when the skin is very active and unstable. Finally, there's a variant of pustular psoriasis called generalized pustular psoriasis. And in this situation, large areas of the skin are affected by redness and swelling of the skin, but they're studded with tiny little sterile pustules. The genetics of psoriasis is complex. Perhaps the most sensible thing to state is that early onset of psoriasis and guttate psoriasis may be associated with this HLA type. The precise pathogenesis of psoriasis is hotly debated, but it's probably a complex interaction between genetics, environmental factors, and aspects of both the innate and adaptive immune responses. What has become apparent over the last 15 years is there are some key inflammatory cytokines which are important in inducing the clinical features of psoriasis. And these include TNF-alpha, interleukin-17, interleukin-23, and knowledge of these basic immunological mechanisms have resulted in development of highly targeted biological therapies which have revolutionized the management of difficult psoriasis. So let's have a look at some of the typical features of chronic plaque psoriasis. As mentioned previously, this produces well-delineated, well-circumscribed, red, silvery scaled patches. They're often symmetrical. This overlying scale may become thick and crack. As the lesions are so well demarcated, it's possible to even draw around the edge of the psoriatic lesions, which you can't do in other things such as discoid eczema. So that clear, well delineated, well marginated edge is the clue to psoriasis. As mentioned, chronic plaque psoriasis affects the elbows, knees, shins, and can then spread elsewhere onto the trunk. And very often it's symmetrical. And here's some images of relatively neglected psoriasis affecting the elbows. So you can see those very well demarcated plaques with thick overlying scale. Elbows, of course, are a very common site for psoriasis to develop. And here's an example of more extensive chronic plaque psoriasis, which happens to actually be on the back, on the trunk, at limbs and scalp. Again, very well demarcated, very well marginated, scaly patches. If you scratch the scale, it often produces this silvery scaled appearance. And in areas you can see that the scale has come away, leaving a rather eroded red area below. So extensive chronic plaque psoriasis. Again, as mentioned previously, psoriasis can become erythrodermic when it affects more than 80% of the surface area of the skin. It can result from progressive extension of chronic plaque psoriasis or may just crop up out of the blue. And erythrodermic psoriasis is probably about the third or fourth most common cause of an erythroderma. Individuals with erythrodermic psoriasis are often shivery, they feel cold, but the skin itself feels hot, and that's because the body is acting like a radiator. So there's loss of both temperature control and fluid control, and this can be a dermatological emergency, and individuals need sensitive topical treatment, admission very often to look after their hydration and temperature control and calorific intake, and very often will need systemic treatment to settle the condition down. And here you can see chronic palmoplantar plaque psoriasis. So you can see on the feet there, thick, very well demarcated areas of scale and redness affecting both soles. Again, you can see psoriasis on the palms. Look how well demarcated it is over the wrist, and the scattered patches of psoriasis extending proximally up there towards the elbows. So palmoplantar plaque psoriasis. Scalp psoriasis is very common. It may be associated with typical chronic plaque psoriasis elsewhere, or it may exist on its own, only in the scalp. So it's very common for the plaques of psoriasis affecting the scalp to extend forward over the hairline. Very often there's psoriasis behind the ear and extending down to the nape of the neck. Again, scratching will produce the typical superficial silvery scaling, so typical of psoriasis, so scalp psoriasis. This is a rather unusual variant of scalp psoriasis called pityriasis amiantacea. So what happens here is that scale is adherent initially to the scalp, but then will extend up the hair shafts, producing what is almost like an overlapping Mediterranean tile appearance. So pityriasis amiantacea can occur in other skin conditions, but psoriasis is probably the commonest cause. It can also occur in bad extensive scalp seborrheic dermatitis. Here's some examples of flexural psoriasis. So you can see psoriasis in the natal cleft. So the typical features of psoriasis are appearing as the buttock skin is affected, but if you were to part the cheeks, you'd see a salmon pink redness which extends right into the skin fold. On the picture showing the presternal and submammary psoriasis, one of the things that happens in flexural psoriasis is the typical overlying scale may become hydrated just because of the humid nature of the skin environment there, and the scale will often come away, so you get very well demarcated red patches with a salmon pink colour. Flexural psoriasis. One particular variant of flexural psoriasis is genital psoriasis. So there you can see on the penis a very well demarcated scaly patch of psoriasis on the glands. So psoriasis can occur on the shaft and on the glands in men, and obviously it can occur in the perigenital areas, perianally, and in the groins. You can see very well demarcated erythema of psoriasis affecting the vulva in the other image. So genital psoriasis can be the source of considerable anxiety and concern. Here's psoriasis in the ear. Again, you can see very well demarcated, scaly patches. Very often there's psoriasis elsewhere, either in the scalp or the retroauricular areas. Psoriasis can affect the nail unit. Perhaps the most common physical sign that we see are multiple thimble-like pits affecting the nail plate. So pitting is perhaps the commonest sign associated with psoriasis. Another common sign that we see is onycholysis, and this is separation of the nail plate from the nail bed below. And you can see this produces this rather yellow, opaque appearance to the end of the fingernail from the as the separation of the distal part of the nail plate from the bed below. Onycholysis, onycho meaning nail lysis splitting. More advanced nail psoriasis showing onycholysis, separation of the nail plate from the nail bed. Subungual hyperkeratosis, so thick skin which is pushing the nail plate up. And very often what you see in psoriasis is at the point where the nail plate is still adherent to the nail bed below, you'll find a yellowish band as illustrated in this image. So pits, onycholysis, subungual hyperkeratosis, yellow bands are the features of nail psoriasis. Guttate psoriasis is a relatively common acute form of psoriasis which occurs at any age but is more common in younger individuals. The best known trigger is that of a streptococcal sore throat, and about 10 days after the onset of the sore throat, tiny little patches of psoriasis develop over the trunk and not uncommonly affecting the face as well. At first, these are about 3 to 5 millimeters, but they can get up to about a centimeter in diameter altogether. So this is an acute onset of drop-like lesions of psoriasis scattered over particularly the trunk, limbs and face. Guttate psoriasis. Localized psoriasis can develop pustules within them, and swabs from these areas will be sterile. So these are sterile neutrophilic pustules which can develop particularly when psoriasis is being irritated by topical treatment particularly. So localized pustular psoriasis. A different kettle of fish altogether is generalized pustular psoriasis, when large areas of the skin become red and are studded with these sterile pustules. They often coalesce to produce lakes of pus within and just under the epidermis. Again, generalized pustular psoriasis is a dermatological emergency. People are feverish, unwell, will have difficulty with temperature and fluid control, and generally need admission, bland topical therapies and systemic treatments to suppress the condition. Finally, another relatively common cause of localized pustular disease, palmoplantar pustulosis or palmoplantar pustular psoriasis. So this tends to affect the palms and soles, may be asymmetrical, may be symmetrical. The skin on the palms and soles is often slightly scaly, and if you look carefully, you can see that pustules have developed within them. Where these pustules rupture, they often leave these characteristic rusty dots. So pustules, rusty dots on the palms and soles. Again, swabs are sterile. This is palmoplantar pustulosis. Psoriasis is a remitting and relapsing condition. So what is it that aggravates stable chronic plaque psoriasis? Well, harsh skin irritants, soaps, detergents will tend to make it flaky and scaly and can exacerbate psoriasis. As mentioned previously, particularly with guttate psoriasis, streptococcal infections, usually of the throat, 10 to 14 days afterwards can result in exacerbations of psoriasis. It's very common for anything which tends to injure the skin, be it a physical injury such as a cut or a burn, a surgical injury, or even sunburn. The skin will react by what is called the Koebner's phenomenon. And this is when psoriasis localizes itself into areas of skin trauma. And as I say, those traumas could be physical injuries, chemical injuries, sunburn. Psoriasis is drawn into the area by what is called the Koebner phenomenon. The majority of patients with psoriasis will improve with ultraviolet light, but about 5% of people notice that the psoriasis gets worse. And very often they've got psoriasis both on the face and the back of the hands, which are obviously high sun exposure areas. So most people improve. About 5% of people have got photosensitive psoriasis. Drugs are well known to exacerbate psoriasis. The drugs that are most commonly implicated are lithium, beta blockers, antimalarials, and the antifungal agent terbinafine. Alcohol, obesity, and smoking can all exacerbate psoriasis, and unfortunately, particularly men with psoriasis will often deal with their psoriasis by drinking fairly heavily, and it does tend to make their psoriasis worse. Psychological stress is a well-known precipitant and exacerbant of psoriasis. Bereavements, accidents, all kinds of psychological stress can exacerbate psoriasis, and continued anxiety and depression does mean that anti-psoriatic treatments don't work as well unless that aspect is addressed. What other health conditions may accompany psoriasis? Well, as mentioned previously, psoriasis can lead to anxiety, depression, isolation, suicide, and that probably is the morbidity that is most commonly associated with extensive psoriasis. Psoriasis can be associated with a chronic seronegative polyarthritis called psoriatic arthritis, and this can affect the small joints, the axial skeleton, and sometimes also the large joints. People with extensive cutaneous psoriasis, the association with psoriatic arthritis might be as high as 20%. So the worse your cutaneous psoriasis, the greater is the chance that you're going to get psoriatic arthritis. Psoriasis may be associated with uveitis, and there's certainly an association between inflammatory bowel disease and psoriasis, and this has some important therapeutic implications. In the last 20 years, we've become to realise that psoriasis is associated with the metabolic syndrome and is an independent risk factor for cardiovascular disease, particularly so in people with extensive psoriasis. Chronic inflammation of the skin may drive the development of atherosclerosis, and as mentioned, psoriasis is an independent risk factor for cardiovascular disease. There's certainly also a link between psoriasis, obesity, and type 2 diabetes. So all of these conditions should be taken into account when assessing people with psoriasis. So what is it that psoriatics hate about their disease? It's very instructive to look at the results of a survey which we tend to do in everybody with a skin disease called the Dermatology Life Quality Index. And this assesses 10 different parameters of life. What do psoriatics hate? Well, one thing they really hate is scale everywhere. So if they're away from home and they take their clothes off, they're very often self-conscious about all the scale that develops on dark carpets. They're very concerned about scale on their clothing from scalp psoriasis producing what looks like really bad dandruff. Obviously, they're concerned about visible disease, particularly when it affects the face, the hands, and the feet, anywhere else that may be visible. They're self-conscious. It affects the clothing that they wear, their activities, and their relationships, particularly with genital psoriasis. Psoriasis can be very itchy and, as a result, can produce sleep disturbance. Psoriasis can be painful and sore, particularly when it's extending and becoming inflammatory. This is particularly the case if the skin fissures, so you get splits from the overlying thick keratin, particularly in mobile skin such as over the elbows, the knees, the palms and soles. The skin splits, you've got fissures, and these can be very sore. And of course, patients are concerned about the burden of their treatment. They don't like usually messy, greasy ointments, topical treatments they find inconvenient. The burden of therapy costs can be great. So these are all things that psoriatics would rank as being their biggest dislikes, the biggest pain of having psoriasis. So what do we do when we're assessing a patient with chronic plaque psoriasis or any other form of psoriasis? Well, first we try and make a estimate of the extent of their psoriasis and what type of psoriasis it is. Is it flexural? Is it genital? Is it nail psoriasis? Is it scalp psoriasis, etc.? We'll ask about exacerbating factors. Is it made worse by pressure and stress? Does sunshine help or hinder? Do any of their treatments help or hinder? Are they intolerant of topical treatments? Can they apply their topical treatments? Are they physically able to apply topical treatments, for example, to their back or to their feet? We should address their general medical condition? Are they smokers? Are they drinking a lot of alcohol? Are they overweight? It's important to ask also in areas where it's available, would they be able to attend for either day case treatment or phototherapy? Because this often involves daily visits to an outpatient treatment area, 3 times a week treatments for phototherapy. And of course, very often people are not able to do this because of distance, work, etc. Important to ask about any coexisting joint symptoms. Obviously important to think about, have they got any other underlying conditions, because that might influence choices of any systemic therapies that we might be considering embarking on. Are they hypertensive? Do they have liver disease? Have they got any chronic infections, previous history of tuberculosis, chronic viral diseases? Have they any previous or current underlying malignancy? Important to ask, is there one thing that bugs you most, so that at least we can direct therapy to the thing that bugs them the greatest? Obviously, try and determine what effect the disease is having on their psyche. So these are all important aspects to cover when assessing somebody with psoriasis. So what are the principles of therapy? I think at last we can be optimistic about psoriasis. There have been huge advances in the biological therapy and small molecule therapy for extensive psoriasis. We've been much poorer at the development of topical treatments for mild to moderate psoriasis, but there may be some advances coming along in the next year or two. Again, probably with small molecule topical treatments, JAK inhibitors, TYK2 inhibitors. So we can be optimistic that if the worst comes to the worst, we do have some amazing treatments available to us now. Firstly, we've got to consider general measures of treating psoriasis. Always important to minimize soap and shower gels because they tend to dry the skin out, make the skin more flaky and scaly. Obviously, the one thing that patients dislike is scale, and dry, scaly skin tends to be more itchy. So avoid soaps and detergents and wash with a light emollient. Which one? The one that they like best of all. In the UK, we've got 60 different prescribable emollients. So I think it's important to have at your grasp an idea of a very light emollient suitable for a substitute, perhaps a medium emollient, a compromise, and which ones are the greasy ones, which most people don't particularly like, but particularly people with really bad psoriasis, they sometimes do. So it's important to give them a choice, listen to what they say, prescribe the ones that they like the most, because if they don't like the emollient you give them, most will stay within the pot. Encourage natural sunlight, because the majority of people with chronic plaque psoriasis do improve with natural light. Only 5% get worse. Consider their cardiovascular risks. Are they smoking? Can you do anything about that? You need to consider looking at their lipid status, etc. Obviously, warn people of the dangers of smoking, excessive alcohol consumption, and obesity, because all of these tend to worsen psoriasis. What specific topical therapies do we have for managing psoriasis? For many, many decades now, we've had coal tar, and this is available in both ointments and more cosmetically acceptable lotions, gels, and creams. A lot of people don't like the smell of coal tar, but some have been formulated so that they are more acceptable. And it's safe, relatively inexpensive, though less and less available as newer agents come along. Dithronol is an extract of coal tar, which was felt at one stage to be the active constituent in coal tar. And dithronol has been used for probably 50 or 60 years. Its main problem is that it stains and it's irritant, but it still is the most effective of topical treatments. And very often a dithronol-induced remission is a long remission. Very often we've got to teach people how to use dithronol in an outpatient day case setting. A lot of people find it too messy to use at home. So obviously the drive is to try and find effective, clean, well-liked topical therapies. For over 30 years now, we've had vitamin D analogues, particularly calcipotriol, and this can be used as either monotherapy or in combination with a topical steroid. So these are products such as Dovabet or Enstellar. Again, they tend to be available as foams and quite heavy creams. For flexural areas such as the face and the flexural areas, armpits, groins, etc., often topical therapies are rather poorly tolerated, and calcineurin antagonists, these are things like tacrolimus, can be very effective. Coming along in the next few years, we will have topical small molecules and other agents such as tapinarof. So we're desperate for more acceptable, effective topical treatments for mild to moderate psoriasis. There's been nowhere near the development there's been in topical treatment as there has been in systemic agents. So I've just been talking about dithronol day case therapy. So these two nurses here are experts in their application. So you can see there's a little pot of dithronol paste and a spatula. The paste is accurately applied to the patches of psoriasis, and then it's powdered on top to stop it spreading. And you can see in the middle panel, this is somebody who's receiving dithronol. Dithronol makes the skin turn this brown colour, but the important thing is that the patches are flattening. And once the patches are completely flat and you can't feel any psoriasis, the dithronol has stopped. The staining will take about a week to go, and often there'll be a long remission, a better remission than with any other topical treatments. So it still is available in some areas, but it needs expertise, time, and commitment from the patient. In the far panel, you can see that dithronol will also stain bedding and clothing. So again, that is a disadvantage, and that's why we often keep the dithronol confined to a day case treatment area, unless a patient is particularly committed and skilled in their self-application. Scalp psoriasis can become very thick and hyperkeratotic, and we have to try and remove this scale from the scalp. And the best way to do that is to use something called coconut oil compound. So this is coconut oil which contains tar, sulfur, and salicylic acid. It's applied liberally to the scalp overnight, then covered in something like a piece of cling film or a plastic shower cap, and it's left on overnight to soak into the scale. The following morning, the scale can gently be combed or picked away, and 3 or 4 nights of coconut oil compound treatment can transform difficult scalp psoriasis. The coconut oil compound can be washed out with a tar shampoo, and then a topical steroid gel or foam can be applied during the day. There's no point in putting a topical steroid onto thick keratin unless it's removed, because it'll just stick there without having any therapeutic effect. Phototherapy can be a very valuable adjunct to treatment that's not being adequately controlled by topical treatment. And we usually treat the full body. There are several types of light that are used, but the most frequently used is 311 nanometer ultraviolet B, sometimes called narrowband UVB. And this is delivered usually in a stand-up phototherapy box, which you can see illustrated there. So the patients go in, leaving on only their underclothes, and they have to have the treatment 3 times a week for 6 weeks. Exposures start off being very short, something like 20 seconds, build up to 2 or 3 minutes. But it's the toing and froing to attend for the treatment which is a slight barrier. There are some domiciliary units which patients can rent out in less populated parts of the world when it's going to be difficult to access a phototherapy unit. Another type of phototherapy that is less frequently used these days is called PUVA. PUVA stands for psoralen UVA. Psoralen is a photosensitizer. UVA alone isn't a very good treatment for psoriasis, but if you photosensitize somebody by either using a topical psoralen delivered in a bath, for example, or a psoralen tablet, it can be much more effective. Treatment is given twice a week, probably more effective than UVB, but it certainly is more carcinogenic and has more in the way of side effects. So probably UVB, narrowband UVB, is used probably 10 or 15 times more frequently these days than PUVA. PUVA can also be delivered to the palms and the soles using a hand and foot unit. And you can see that somebody's having topical PUVA in the right-hand panel. We now have a number of systemic therapies for psoriasis that's either inadequately controlled with topical treatments, inadequately controlled with phototherapy, or where phototherapy is really a non-starter because of convenience, distance, etc. So we've got vitamin A derivatives. So these are called retinoids. The agent we use is called acitretin. It's reasonably effective. Generally, you're going to know within 8 to 12 weeks whether it's producing a satisfactory effect. Downsides are that it can produce hypertriglyceridemia and occasionally will cause liver enzyme derangements. It's a potent teratogen, so we don't use this in women of childbearing age. Perhaps the most frequently used first systemic agent is methotrexate. Methotrexate is given once weekly. It can be given either orally or by a subcutaneous route. And we use anywhere between 5 and 30 milligrams weekly. We usually give it with folic acid supplements to prevent some of the side effects of methotrexate. And methotrexate, again, we will often start at a low dose, escalate the dose up, but if it's going to work, you're generally going to see improvement by week 12. In the short term, it can be a marrow suppressive. There are a number of potential drug interactions with methotrexate. In the long term, it can be hepatotoxic, so alcohol should be kept to a minimum in patients taking methotrexate. But methotrexate can be used long term. We have patients who have been on satisfactory controlled methotrexate for 10, 15 years, but it does need monitoring both of bloods and also to assess for the development of liver fibrosis. Clearly, should that happen, the drug is stopped and we move to something else. The systemic calcineurin antagonist cyclosporin has been used for about 30 years in psoriasis. We use about 3 milligrams per kilogram a day, so much lower doses than is used, for example, after heart transplant. It works quickly, but the downside is there's almost inevitable eventual renal damage, deteriorating renal function and hypertension. So we tend to limit cyclosporin to about 3 to 6 months. So, for example, if someone's coming up to an important event like exams or a wedding and they want rapid control of the psoriasis, we may use cyclosporin, but generally not for more than 6 months. It needs close monitoring, blood pressure, renal function, and again, we would use considerable caution if there's any underlying malignancy. One of its advantages is that it's not teratogenic and it's one of the few agents we can use in pregnancy if we need to. To other agents that have been around for about 10 years now, apremilast, which is a phosphodiesterase 4 antagonist. It's used to treat both cutaneous psoriasis and psoriatic arthritis, and an immunosuppressant, dimethyl fumarate, which has been very popular in Germany. Biological agents have revolutionized difficult psoriasis since the early 2000s, but the main problem is they're very costly. However, they're given by injection and usually within 16 weeks, about 80 to 90% of people can be either clear or almost clear. So we have biological agents of different classes. So we've got tumor necrosis factor alpha inhibitors. So this is infliximab, which tends to need to be given intravenously, adalimumab, etanercept, and sertolizumab. These all target TNF, and the latter are given subcutaneously. We've now got some biosimilar agents. So we have biosimilar adalimumab, and this has cut the cost in the UK from £9,000 a year to about £1,000 a year, or $1,500 US dollars annually. So the biosimilar biological agents are working out much, much cheaper and just as effective as the progenitor drugs. They need minimal monitoring. And one problem we do see is that it does increase the risk of tuberculosis. So pre-treatment, people need to have rigorous assessment that they haven't had previous tuberculosis, chest x-rays, quantiferon tests. Also, we would avoid these agents in any chronic underlying, particularly viral infections such as hepatitis B, C, and HIV. Newer agents we have agents which target interleukin-17. So these are secukinumab, ixekizumab, brodalumab, and bimekizumab. These are all very effective. Again, can produce 80 to 90% suppression of psoriasis in 80 to 90% of people. They should be avoided in people who've got inflammatory bowel disease. In fact, very occasionally they will induce inflammatory bowel disease, and they can increase the incidence of mucocutaneous candidiasis. Then we've got agents which target interleukin-23, ustekinumab, guselkumab, tildrakizumab, risankizumab. Again, they have no effect on inflammatory bowel disease, and in fact, they can be used to treat inflammatory bowel disease. And the majority of these agents, not only do they help cutaneous psoriasis, they will also help psoriatic arthritis. And to add to the armamentarium, we now have both oral JAK inhibitors and tyrosine kinase 2 antagonists for the treatment of cutaneous psoriasis. So psoriasis, lots of optimism. We've had some fantastic treatments come along in the last 15 years. Really, these days, really nobody should have really bad psoriasis because we've got a mass of different therapeutic avenues. Where the problem really lies is we don't have good topical treatments for those who've got mild to moderate psoriasis, but hopefully things are around the corner. So enjoy psoriasis, be optimistic. It's never been such a good time for psoriasis.